Let's go over the risk factors for infective endocarditis. These include prosthetic valves being implanted in the patient, or he is IV drug user, most commonly heroin, or he is on immunosuppression therapy, or he is undergoing dental procedures which include mucosal perforation, basically bleeding from the gums, or he has history of previous endocarditis, or he has cyanotic heart disease which has been unrepaired or has been recently repaired. And what are the cyanotic heart diseases? Tetralogy of Fallot, transposition of the great arteries, truncus arteriosus, tricuspid atresia, total anomalous pulmonary venous return. Or the patient has congenital valve disease, most commonly mitral valve prolapse. Something very important I would like you to know here is the following. Mitral valve prolapse, acute rheumatic fever, and myocardial infarction, all of these can lead to mitral regurgitation as a complication. But the way it happens is very important for you to know because they're gonna ask you on the exams. So in mitral valve prolapse and in acute rheumatic fever, which results in rheumatic heart disease, here the mitral regurgitation happens because of rupture of the chordate tendineae of the valve. Whereas in myocardial infarction, there is again a rupture, but of the papillary muscles of the heart valve. That's how you're gonna end up with mitral regurg here. So please make sure you know this because you're gonna get tested on this. Let's go over the most common causes of acute bacterial endocarditis. So let's start with Viridian streptococci. It is the most common cause in patients with native valves, basically their own valves, undergoing dental or respiratory tract procedures involving mucosal bleeding. Then we have Staphylococcus aureus. It's most commonly seen in IV drug users and in patients with implanted cardiac devices and prosthetic valves. Staphylococcus epidermidis infective endocarditis is also seen in patients with prosthetic valves. Streptococcus gallolyticus, also known as Streptococcus bovis, is most commonly seen in patients with colon cancer and inflammatory bowel disease. So make sure that when you find this infection, you perform a colonoscopy immediately. And lastly, Candida and Aspergillus is seen most commonly in patients with long-term indwelling catheters or immunosuppressed patients with AIDS, organ transplants, or malignancies. Let's see with what kind of signs and symptoms can our patient with infective endocarditis present with. So this is our patient here, so let's start from the head down. He can have signs and symptoms of stroke, and depending on the blood vessel that has been occluded by an emboli, he can have different signs and symptoms, right? For example, focal neurologic deficits, weakness or paralysis in the limbs. Now moving on to the eyes here, these red dots are actually retinal hemorrhages called rod spots. The patient can also present with fever which is more than 38.3 Celsius and more than 101 Fahrenheit. Also he can have septic pulmonary emboli here in the lungs, and on EKG we can actually see AV blocks, which is suggestive of perivalvular abscess. And also we can hear two murmurs, tricuspid regurg and mitral regurgitation. Both of them are holosystolic murmurs. So how are we differentiate between them? The mitral regurg is a murmur which you increase on expiration and with the hand grip maneuver, basically when you increase the afterload. Whereas the tricuspid regurg is a murmur which you increase on inspiration and with the Valsalva maneuver, basically when you hold your breath like this. And what are you doing by doing this? You're decreasing the preload. Okay, moving on. Now we can also observe splenomegaly and hematuria if the spleen and the kidneys are also involved. Also under the nails we can observe the so-called splinter hemorrhages, whereas on the finger pads here and on the toe pads we can see what is called osler nodes. These are painful raised bumps, whereas on the palms and on the soles we can see Janeway lesions, which are non-painful, and basically these are peripheral hemorrhages due to embolization again. So if a patient arrives at the hospital with a fever of more than 38.3 degrees Celsius and a new heart murmur, then this is super suggestive of infective endocarditis. So what do you want to do first? Yes, you want to take two blood cultures from two different sites. Remember, two blood cultures from two different sites. It's very important. So you're expecting the blood culture to come back positive, right? But what if it comes back negative? Yes, now you have to start thinking of microorganisms that are negative on blood culture, which are the Hasek organisms: Haemophilus, Actinobacillus, Cardiobacterium, Echinella and Kingella. Remember these five. But on the exam, if they ask you what are the most common reasons for negative blood culture, the answer will be Coxiella and Bartonella. But wait, is there another reason why the blood culture would come back negative when the patient is actually having infective endocarditis? Yes, there is one. For example, if you start the patient on antibiotics before you take the blood cultures. This is a very big mistake, and it's very tested on the exams. So make sure you take the blood cultures from the two different sites before you start the antibiotics. Because if you start the antibiotics first, the blood culture might come back negative. But if the culture does come back positive, now you have to confirm your diagnosis. And how do we do that? With the TTE, to look for valvular vegetations. And if the TT is positive, alright, now you have to start treating the patient. But if it's negative, now you have to perform another test, which is the invasive one, the transesophageal echocardiography, because this test is more specific and sensitive than the TTE. Luckily, here we have a specific criteria called the modified Duke's criteria to diagnose infective endocarditis, so there is no confusion about it. And you're seeing it right here. For a definitive diagnosis, we require 2 major and 1 minor criteria, or 1 major and 3 minor criteria, or 5 minor criteria. The major criteria include persistently positive blood cultures, which means 2 positive blood cultures drawn 12 hours apart, and positive echocardiogram for infective endocarditis, which can include oscillating intracardiac mass on the valve or supporting structures, or in the path of regurgitant jets, or on implanted material in the absence of an alternative anatomical explanation, or if you see an abscess or a new valvular regurgitation. The minor criteria include predisposing heart condition or IV drug user, fever more than 38 degrees Celsius, vascular phenomena like major arterial emboli, septic pulmonary infarct, mycotic aneurysm, intracranial hemorrhage, conjunctival hemorrhages, and genuine lesions. Also immunologic phenomena like glomerulonephritis, Osler nodes, Rhodes spots, and rheumatoid factor. And also microbiologic evidence like positive blood cultures but not meeting the major criteria that we just discussed. And of course, echocardiographic findings consistent with infective endocarditis. If our patient is acutely ill right now, we should not wait for the blood cultures to come back with the results in 1 to 3 days, right? We should start them on empiric therapy, and it is as follows. Now, for community-acquired native valve infective endocarditis, we want to cover the most common organisms that are causing it, like the MRSA and the methicillin-sensitive Staph aureus and Strep viridans. And how do we do that? With vancomycin and gentamicin. Now, on the other hand, if the infective endocarditis has been acquired in the hospital after 72 hours after admission, basically what is called nosocomial infection, then you want to cover multi-resistant bacteria and especially the coagulase negative staphylococci, which are Staph saprophyticus and Staph epidermidis. Alright, so we do this again with Vanco and Genta, but we add rifampin and anti-pseudomonal beta-lactam antibiotic like the carbapenems. Also, apart from that, if the patient has prostatic valve infective endocarditis, we want to give them Vanco, Genta and rifampin again. And if the patient has Hasek infective endocarditis, you want to treat him with ceftriaxone. And when the blood culture comes back with the results, you have to tailor your treatment depending on the sensitivity of the causing agent. And if this microorganism is penicillin sensitive, then we're gonna treat our patient with IV penicillin G or IV ceftriaxone. Let's go over the surgical indications in patients with infective endocarditis, as these are very heavily tested and you actually need them in your clinical practice. So the first one is the valvular dysfunction and acute heart failure. In patients with acute heart failure, the mortality is very big, so you want to perform surgery as soon as possible. Fungal infection or highly multi-resistant organism. For example, if you have infective endocarditis caused by Candida or Aspergillus, they normally come with very big vegetations, and the amphotericin B doesn't actually penetrate properly into the vegetation, so you actually want to perform surgery and take this out of the heart. Now, if you have prostatic valve and Staph aureus infection, you have to replace the prostatic valve. You also want to replace this prostatic valve if it has dehiscence. Basically, it's not working properly anymore. It's not in place like the way you want it to be. Also, if you have aortic valve abscess, as we said, the perivalvular abscess in the aorta can lead to AV block, so it's very important for you to perform surgery here as well. Also, if you have systemic embolization on antibiotic therapy, like we said, stroke, septic pulmonary emboli, these are all indications for surgical intervention in these patients. And also, if you have cardiac implant, like the devices like loop recorders or pacemakers, you have to take the device out and replace it with a new one. And here we have another super high yield indications, the indications for pre-procedure antibiotic prophylaxis. Basically, we want to give antibiotics to patients who are at very high risk of adverse effects if they acquire infective endocarditis. So we're gonna go over the patients here and we're gonna go over the procedures after that. So the patients that are high risk are the ones who have prosthetic valves implanted, or they have history of previous endocarditis, or they have cyanotic congenital heart disease which has been unrepaired or has been repaired recently with residual defects though. And what are the congenital cyanotic heart diseases? The 5 T's, right? Tetralogy of Fallot, tricuspid arthrasia, transposition of the great arteries, truncus arteriosus, and total anomalous pulmonary venous return. Alright, moving on. If the patient has had the congenital heart disease which has been repaired in the last 6 months, then you also have to give them prophylaxis. And also, if they have valvular disease after heart transplant, they also need antibiotic prophylaxis. So let's see now what are the procedures, the high-risk procedures. If the patients that we just mentioned are undergoing any of the following procedures, then they need pre-exposure antibiotic prophylaxis. And the procedures are these: dental procedures with mucosal perforation and gingival bleeding, respiratory tract mucosal incisions and biopsies. Basically, when there is bleeding, there is high risk. Also GI and GU surgeries in patients with GI and GU infections, and patients who are having surgery on infected skin or muscle, and patients who have to get implanted prostatic cardiac material. The preferred antibiotic prophylaxis is amoxicillin 2 grams per os. But if the patient cannot take oral medications, you can give them ampicillin 2 mg IM or IV, or cefazolin or ceftriaxone 1 gram, again IM or IV. If the patient is allergic to penicillin or oral ampicillin, you can start them on cephalexin 2 grams per os, or clindamycin 600 mg per os, or azithromycin or clarithromycin 5 mg per os. And if the patient is allergic to penicillin or ampicillin and can take oral medications, then you can start them on cefazolin or ceftriaxone 1 gram IM or IV, or clindamycin 600 mg IM or IV. Also, make sure to remember and keep note that the preferred antibiotic for gingival and respiratory tract procedure is amoxicillin, for GU and GI procedure is ampicillin, and for skin and muscle procedures and prostatic cardiac material placement is vancomycin. Let's go over the high yield points for acute rheumatic fever. As we all know, it is caused by pharyngeal infection with strep pyogenes. And strep pyogenes, now we know that it is a group A streptococci which has beta hemolysis, which is complete hemolysis. Alright, so it happens usually in kids, and after 2 to 3 weeks after the infection, the kid will present with acute rheumatic fever. And the first presentation is actually migratory polyarthritis, and the large joints are the most affected ones. Alright, so you also have to know what type of reaction is this. This is immune-mediated cytotoxic hypersensitivity to reaction. So you know, maybe you remember that the type 2 hypersensitivity involves antibody and antigen. And here in our case we have IgM autoantibody against the M protein in the capsule of strep pyogenes. Another cool thing you need to know is that the group A streptococci, which is strep pyogenes, can cause also skin infection. And a side effect of this skin infection is glomerulonephritis. Whereas if the strep pyogenes is causing pharyngeal infection, then the patient can have as a side effect acute rheumatic fever and glomerulonephritis. But if you test for the strep pyogenes with the rapid strep test and after that with throat culture, and you diagnose strep pyogenes pharyngitis and you treat it with amoxicillin, then the acute rheumatic fever is preventable. Okay, you don't have to have this side effect. But on the other hand, glomerulonephritis cannot be prevented with anything. The early side effects of pharyngeal infection with strep pyogenes is, as we said, acute rheumatic fever, but also death from myocarditis. And the late side effects are rheumatic heart disease, which presents most commonly with mitral regurg or mitral stenosis, followed by aortic regurg and aortic stenosis, and lastly it can affect also the tricuspid valve. In 2015, the ACC revised the Jones criteria for diagnosing acute rheumatic fever. So the diagnosis of an initial episode of acute rheumatic fever requires 2 major criteria or 1 major plus 2 minor criteria. And these are as follows. The major criteria are carditis, which can be clinical or subclinical, arthritis, which can be polyarthritis, monoarthritis or polyarthralgia, chorea, erythema marginatum, and subcutaneous nodules. Whereas the minor criteria are oligoarthralgia, fever equal or more than 38.5 degrees Celsius, ESR more than 60 millimeters, and CRP protein more than 3 milligrams per deciliter, and prolonged peer interval.